I wanted to welcome today one of our own, Dr. Sanjana Koshy, who, as you probably know, is an assistant professor of medicine here in the Division of Infectious Disease, and also the director of our antimicrobial stewardship program, both here and across the street of New York, Ioneer, and in Brooklyn. And we're delighted to have her here today talking about the therapeutic management of COVID-19. Dr. Koshy.
Thank you. Thank you, Dr. Weissman, for that introduction, and for the opportunity to present an update on COVID-19 therapeutics based on clinical research from the last 10 months. I'm clear, right? You can hear me? All right. Okay, great. Thank you. Financial disclosures. I have family who have a very minor ownership interest in Lilly and Pfizer. I plan to discuss Remdesaver as antiviral therapy, briefly talk about steroids, the various new immune-based therapies, and finally go through the national guidelines and our Mount Sinai Health System guidelines, treatment guidelines for COVID-19. So, so the pathogenesis of COVID-19. All of these treatments that I'm going to talk about are based on the pathogenesis of COVID-19, which we believe involves an early replication of SARS-CoV-2, during which we use the antiviral therapies, and there is a later exaggerated immune inflammatory response that leads to tissue damage. At this stage, we use the immunosuppressives and anti-inflammatory therapies. In the very early stages of infection, even before the host has mounted an effective immune response, we think that anti-SARS-CoV-2 antibody-based therapies may have the greatest likelihood of having an effect, almost like antivirals. And that is what we're going to be talking about. So antiviral therapy, Remdesivir. Remdesivir is a nucleotide analog. It inhibits RNA-dependent RNA polymerase. It is FDA approved now for the treatment of COVID-19 as of October this year. Earlier in May, it was under an emergency use authorization. It should only be administered in a hospital or in a healthcare setting capable of providing acute care comparable to inpatient hospital care. And I want to go through over the next several slides, the two big randomized studies that led to approval, which is Act 1, and of course the Solidarity trial, and then some of the other studies involving Remdesivir. We were a site for several of these Remdesivir studies. I was the site investigator, so I'm happy to see the progression of this drug from research into full FDA approval. So the Act 1. Act 1 is the Adaptive COVID Treatment Trial 1. It's an NIH-sponsored, multinational, randomized, double-blinded, placebo-controlled study of over 1,000 patients. The median time from symptom onset to randomization was approximately 9 days. Remdesivir was given for a total of 10 days or until hospital discharge or death. The primary endpoint for this study was time to recovery, either discharge or remaining in the hospital for just infection control purposes. Remdesivir had a median recovery time of 10 days as compared with 15 days in the placebo group, and this was statistically significant. This benefit was clearest in the subgroup of patients who required low-flow supplemental oxygen, which was also the group that had the greatest participants in the study with an N of 435. This effect was not very well seen in patients who were not on oxygen, was not very clear in patients who were receiving high flow or non-invasive mechanical ventilation, and clearly not seen at all in patients receiving mechanical ventilation or ECMO. Once again, when you look at the forest plots, looking at time to recovery according to subgroup based on baseline oxygen requirements, the largest group was the ordinal scale 5, which was patients requiring oxygen through nasal cannula. And this was the group that showed the clearest benefit for remdesivir compared to placebo. Mechanical ventilation and ECMO, clearly there was no benefit at all. Mortality, at day 29, it was 11.4% with remdesivir, 15.2% with placebo, so not really statistically significant. But when you looked at, once again, mortality at day 29 by subgroup based on baseline severity and oxygen requirements, the greatest difference was observed in the subgroup requiring supplemental oxygen with a hazard ratio of 0.30. So again, low flow oxygen, remdesivir, showed clinical efficacy, both in terms of time to clinical improvement and in terms of mortality. When you look at adverse events, there was really no significant difference between the remdesivir group or the placebo. The next large trial was the WHO Solidarity trial. This is a large, simple, international, open-label randomized trial involving hospitalized patients with COVID-19, 405 hospitals in 30 countries with over 11,000 adult participants enrolled. It was a highly diverse population with high-income countries like Canada, France, Switzerland, low and middle-income countries like Peru, Philippines, and South Africa. The goal was to study the effects of 4 repurposed antiviral drugs on mortality: remdesivir, hydroxychloroquine, lopinavir, and interferon beta 1A. Hydroxychloroquine, lopinavir, and interferon were dropped around July from the trial for futility in hospitalized patients. So looking at the primary outcome was in-hospital mortality, regardless of whether death occurred before or after day 28. Secondary outcomes were the initiation of mechanical ventilation and duration of hospitalization. We don't have data on the median duration of symptoms in this patient population, but we do know that 62% of patients underwent randomization at day 0 or 1 of hospitalization. So looking at the results, these are the effects of in-hospital mortality of remdesivir compared to its own control. Had 2,743 patients in the remdesivir arm and 2,708 control. And the two lines were completely almost superimposed on each other, showing really no difference between control and remdesivir in terms of in-hospital mortality. The secondary endpoints looked at was the initiation of mechanical ventilation. And again, the numbers showed absolutely no difference. And the second secondary endpoint was time to discharge alive in all patients, regardless of respiratory support at entry. And again, between remdesivir and its control, there was no significant difference. Third study, the third of the randomized remdesivir study was this study from China, which looked at adults with severe COVID-19. It was randomized, double-blinded, placebo-controlled, multi-center. This was actually one of the earliest studies released in April or May, and it enrolled about 237 patients and found that remdesivir use was not associated with a difference in time to clinical improvement. One of the big critiques of this study was that it was done at a time when China did not have as many COVID-19 patients. So the study did not reach target enrollment and was insufficiently powered to detect differences in clinical outcomes. So going back to the Solidarity data, they actually did a meta-analysis of mortality in all trials of random assignment of remdesivir or its control in hospitalized patients, and did this nice forest plot looking at Solidarity, Act 1, and then a couple of the Chinese trials that were done. They stratified them based on oxygen use. And I would like to point out that Solidarity did not break out the low flow and high flow oxygen into two different categories. They were both put together as one, as opposed to Act 1, which separated patients into low flow and high flow oxygen. The only finding of statistical significance in terms of mortality was in Act 1 in patients requiring low flow oxygen, which had a hazard ratio of 0.30. So that is where we stand with the randomized studies involving Remdesivir, which led to the WHO, after releasing the Solidarity data, updating their guideline without suggesting the use of Remdesivir for patients who were hospitalized and with severe COVID pneumonia. So moving on to the other Remdesivir studies, and these are the industry-funded Remdesivir trials, which we were a part of at Mount Sinai, Beth as well. This is 5773, looking at hospitalized patients with severe COVID pneumonia, defined as having oxygen saturations at 94% or less. And this looked at whether there was a difference between 5 or 10 days of Remdesivir use. Patients were randomized to 5 or 10 days of Remdesivir, open label study. It excluded patients requiring mechanical ventilation and ECMO. And by day 14, we found that the 10-day treatment course of Remdesivir was comparable to 5 days. Among the few patients who did go on to receive mechanical ventilation or ECMO, at day 5, the mortality was numerically greater in the 5-day group versus the 10-day group. And so this group, that is the patients who were on mechanical ventilation or ECMO, may benefit from extending treatment to 10 days as opposed to 5 days. And then we also were a part of the 5774 study, which looked at patients with moderate COVID-19 hospitalized patients. So these were hospitalized patients with moderate COVID-19, defined as having oxygen saturations greater than 94%. Patients were randomized to receive either 5 days of Remdesivir, 10 days of Remdesivir, or standard of care. Again, this was an open label study. And at day 11, the 5-day Remdesivir group was more likely to have recovered or clinically improved compared to the standard of care group. It was interesting to note that the median length of treatment was 5 days for patients in the 5-day group, but only 6 days for patients in the 10-day group, telling us that you really probably did not need 10 days of Remdesivir in this group. Most of the patients were discharged before they completed 10 days of Remdesivir. So Remdesivir is now FDA approved for the treatment of COVID-19. It is not recommended in patients with eGFRs less than 30 milliliters per minute. There is also the risk of increased transaminase elevations and hepatic toxicity. We recommend that patients get a complete metabolic profile before they start Remdesivir and daily while receiving Remdesivir in the hospital. For patients not requiring invasive mechanical ventilation or ECMO, the recommended duration of treatment is 5 days. And for patients requiring mechanical ventilation or ECMO, the duration of treatment is recommended is 10 days. Before leaving the topic of Remdesivir, I want to go through a couple of these combination therapies, especially as this combination of Remdesivir and the Janus kinase inhibitor baricitinib did get an EUA authorization by the FDA last month. I think in today's there was a report, the actual published study was actually published today in the New England Journal. I have not had the time to review that. So this information is primarily from the EUA data. This is from Act 2, which is the second of the adaptive 19 COVID treatment trials, looking at hospitalized patients with COVID-19 infection. Randomized, double-blinded, placebo-controlled study, looking at a combination of baricitinib plus Remdesivir with placebo plus Remdesivir enrolled over 1,000 patients and found that there was improved median time to recovery by 1 day, better clinical status at day 15, and the odds of progressing to death or mechanical ventilation at day 29 was lower. All of this was statistically significant, but has to be weighed against the unclear role of steroids in these patients. I don't think that was studied, and that is something which needs to be looked at further. The cost of baricitinib and the risk of thrombosis. So most national guidelines, including the system, my Mount Sinai Health System's updated guidelines, do not recommend the use of baricitinib at this point. It is available under an emergency use authorization. It can be administered orally for a total treatment duration of 14 days or until hospital discharge. You do need baseline labs and dose adjustments for patients with laboratory abnormalities. Not recommended for patients with renal disease, with active tuberculosis. And again, we don't have much information on the use of baricitinib in combination with systemic steroids at this time. There are warnings, including the risk for thrombosis. Other antiviral immunomodulatory studies under evaluation. The first is we have Act 3, which looks at interferon alpha with remdesivir alone. Remdacta, looking at remdesivir plus tocilizumab compared to remdesivir plus placebo in hospitalized patients with severe COVID-19 pneumonia. And finally, we have the sub-study of Active 3, where patients were randomized to get remdesivir in both arms and compared to bamlanivimab, one of the monoclonal antibodies we will be talking about later, or placebo. This study, actually, enrollment into this sub-study was stopped due to lack of clinical benefit in hospitalized patients. We'll talk a little more about this when we talk about the antibody therapies. So moving on to steroids, and I'm sure my pulmonary colleagues know way more about this than I do. So I only want to briefly touch upon the recovery trial and dexamethasone because that is a part of our guidelines. So the recovery trial was an open label controlled trial in the United Kingdom. Patients were randomized to receive dexamethasone, hydroxychloroquine, lopinavir, ritonavir, azithromycin, tocilizumab, convalescent plasma, Regeneron CoV-2, that is the combination monoclonal antibody, and there's now an aspirin and a colchicine arm. Some of these arms have been stopped for futility. They are hydroxychloroquine and lopinavir, ritonavir. So looking at the dexamethasone cohort, patients were randomized, 2,104 participants were randomized to receive either oral or intravenous dexamethasone. I'm sorry, they had 2,104 participants in the dexamethasone arm and 4,000 participants in the standard of care arm. Patients received 6 milligrams daily for up to 10 days or usual care. The median duration of treatment was actually 7 days. The primary outcome considered was all-cause mortality within 28 days of randomization. And this primary outcome was looked at in pre-specified subgroups, including age, sex, level of respiratory support, days since symptom onset, and also predicted 28-day mortality risk. And I think we have all seen this forest plot looking at the effect of dexamethasone on 28-day mortality according to respiratory support at randomization. Overall, there was statistically significant benefit to the use of dexamethasone. This was especially seen in patients who needed invasive mechanical ventilation, but was also seen to some extent in anyone who received oxygen therapy. There was no benefit in patients who did not receive oxygen. In fact, there was a likelihood of harm in this group. And when we look at the various subgroups who received dexamethasone and the 28-day mortality based on the pre-specified baseline characteristic, we see that there was a statistically significant benefit in patients who were below the age of 17, who had symptoms for greater than 7 days, in addition to a general overall benefit in dexamethasone. This is a meta-analysis looking at the use of systemic steroids in critically ill patients, which also shows that there is benefit. And this is primarily driven by the largest number of patients from recovery. I thought this was a really nice way of looking at all of the DEXA studies in critically ill patients, all of the steroid studies in critically ill patients, which showed a significant benefit. So moving on to what is new in the treatment guidelines, and that is antibody therapies. So these are laboratory produced virus neutralizing monoclonal antibodies, which are directed against the spike protein on the surface of the virus. We believe that the spike protein attaches to the ACE2 receptor on the host cell, leading to viral entry into the host cell and subsequent viral replication. The goal of these monoclonal antibodies is to bind with the spike protein, preventing this attachment to the ACE2 receptor and subsequent viral replication. So the two therapies that are available right now is bamlanivimab and the combination product of casirivimab and imdevimab. I've tried pronouncing this for a really long time and I still stumble. So this combination can actually prevent viral escape by binding to non-overlapping epitopes on the receptor binding domain of the SARS-CoV-2 spike protein. Now, these monoclonal antibodies are being studied in different patient populations. They are being looked at in patients who have COVID-19 and are hospitalized. They're being looked at in patients who have COVID-19 and who are not hospitalized. And they're also being looked at in patients who have been exposed to COVID-19 and as a post-exposure prophylaxis. Mount Sinai Health System has been involved in all of these clinical trials. So looking at antibody therapies in the hospitalized patients, and this is probably the easier one, with bamlanivimab, like I mentioned when we were talking about Remdesaver, it was a sub-study in the larger ACTIV-3 clinical trial where hospitalized patients were randomized to either bamlanivimab or placebo, each in addition to Remdesaver. And this was the trial which was where the enrollment into this sub-study was stopped in October due to lack of clinical benefit in hospitalized patients. The second is the Regeneron combination antibody therapy. And this was also being studied in a randomized placebo-controlled study in hospitalized patients. And in October, the Independent Data Safety Monitoring Committee recommended holding enrollment in hospitalized patients with high oxygen requirements and including intubation. They will continue to enroll patients with low or no oxygen requirements. This was based on a potential safety signal and an unfavorable risk-benefit profile. So at this time, and again, studies are ongoing, antibody therapy does not look like it is a promising option for hospitalized patients, primarily because we feel that most hospitalized patients already probably have mounted an immune response. So looking at hospitalized the antibody therapies in the non-hospitalized patients, And these are where the two EUAs for bamlanivimab and the Cassie combination came out in November. They are pretty much similar. BAM has, there is an article in the New England Journal. Cassie is yet to be published in a peer-reviewed journal. And both trials enrolled, BAM enrolled about 452 subjects, casirivimab 800 subjects. Everyone had to have a diagnosis of COVID-19 with at least one symptom of moderate or mild severity. The median, the average duration of symptoms, mean and the median here, was about 3 to 5 days. Everyone was infused with the monoclonal antibody combination within 3 days of a positive SARS-CoV-2 test. And the primary data which led to the EUA was a shorter median time to symptom improvement, 6 versus 8 days in bamlanivimab, 5 versus 6 days in the Cassie group, and also a lower proportion of COVID-19 related hospitalizations or emergency room visits compared to placebo, especially in patients with risk factors for disease progression. And this was statistically significant, 3 versus 10 and 3 versus 9 in both of these groups. So this led to the emergency use authorization, and this treatment is now available. This is a poster from our colleagues at the American College of Emergency Physicians, which goes through the various points of the EUA. It is only for hospitalized patients who do not require oxygen therapy. And I'm sorry, it is only for ambulatory patients. You cannot give it to hospitalized patients or anyone who requires oxygen therapy or anyone who uses baseline oxygen for other conditions and has an increase in their oxygen demand because of COVID-19. The high-risk patients are fairly broad. They include patients who have a body mass index greater than 35, who have chronic kidney disease, diabetes, who are immunosuppressed or receiving an immunosuppressive treatment, who are over the age of 65 or older, or over the age of 55 and have either cardiovascular disease or hypertension or COPD. And they're also available for the pediatric population between the ages of 12 to 17 with all of these high-risk factors which contribute to disease progression. So we have these monoclonal antibodies in the Mount Sinai Health System. We get a weekly allocation based on our 7-day hospitalization rates. It is a very limited number. To give you an idea of how limited, in the very first week that we got this allocation, Mount Sinai Beth Israel got 2 doses and Mount Sinai Brooklyn got 3 doses. That's improved a little bit now. We have a process of being able to access these monoclonal antibodies. They are being infused at Mount Sinai Hospital because of the logistics of giving it to ambulatory patients who are COVID positive in any of the other hospitals. So the workflow process is that if anybody in any provider in the ambulatory world identifies a patient who might benefit and who is within 5 days of symptoms, please email patient and provider information to COVID Therapeutic Referrals at mountsinai.org. They then screen the patient and based on availability will schedule the patient for an infusion at the Mount Sinai Hospital. We are working on a process for pediatric patients, which will most likely be at the Mount Sinai Beth Israel emergency room. So that is where we are. We are committed to the equitable distribution of this monoclonal antibody. and would really like to get to patients who might not otherwise, which are to patient populations who might otherwise not typically receive them. So moving on to the guidelines. The WHO guideline, which is the international guideline, as we had discussed briefly with Remdesivir, only recommends the use of corticosteroids for patients with severe and critical COVID-19. They did not make a recommendation for Remdesivir. The NIH guidelines, which were recently updated to include this group of not hospitalized patients with mild to moderate COVID-19. This is the group which might benefit from the monoclonal antibody therapy. The NIH recognized that these were available through an emergency use authorization, but did not make a recommendation as they felt that the data at this point was insufficient to make a recommendation either for or against any specific antiviral or antibody therapy. We do not recommend antivirals for this patient population, and based on recovery data, we do not recommend, and the NIH does not recommend dexamethasone for this patient population. The Mount Sinai Health System guidelines pretty closely align with the NIH guidelines also. The second category looks at patients who are hospitalized but do not require supplemental oxygen. Again, based on recovery, dexamethasone is not recommended for this patient population. There are insufficient data to recommend for or against the use of Remdesivir. We do have 5774, which was a study of hospitalized patients not requiring oxygen supplementation. And there may be a case for using Remdesivir in patients at high risk for disease progression. The next category is hospitalized patients requiring supplemental oxygen through a low flow nasal device, not through a high flow device, not invasive or non-invasive mechanical ventilation or ECMO. Like in this population, again, Remdesivir can be used. Dexamethasone can be used, and this combination of dexamethasone plus Remdesivir is basically based on recovery for Remdesivir, Act 1, recovery for dexamethasone, Act 1 for Remdesivir. The combination in itself has not been studied. In hospitalized patients that require oxygen delivery through a high flow device or non-invasive ventilation, dexamethasone, and you could consider dexamethasone plus Remdesivir. And for hospitalized patients who require invasive mechanical ventilation or ECMO, dexamethasone is the only NIH recommended treatment option. So the one thing that we do not see in both the WHO guidelines and the NIH guidelines is convalescent plasma. And so I want to spend the next few slides going through what we know about convalescent plasma. Historically, we know that, that patients who recover from any viral infection often produce neutralizing antibodies, which can be used as either prophylaxis or treatment. This was the basis of the expanded access to convalescent plasma for the treatment of patients with COVID-19. This was a joint effort between the Mayo Clinic and the United States government. It was very popular, and we were also a site. We've enrolled over 50 patients, I think, in the EAP program. The primary endpoint was actually to look at the availability of convalescent plasma. They also wanted to look at adverse events and look for any potential efficacy. Like I said, this program was fairly popular at this point. I think before it went into the EAP, I think they enrolled close to, before it went into the emergency use authorization, I think they enrolled over 90,000 patients. And the Mayo Clinic did publish this safety update on convalescent plasma. data suggests relative safety. The rate of transfusion reactions, thromboembolic or thrombotic events was fairly low. Cardiac events slightly more, but still low. Efficacy is another issue altogether. So this was a study that was published out of Mount Sinai Hospital, one of the earliest studies looking at efficacy. It was a propensity score matched control study of 39 patients, retrospectively propensity score matched to control patients admitted during the same period. And convalescent plasma recipients were more likely to survive than controls in this small cohort. And subgroup analysis suggested that there was a benefit of plasma in patients who were non-intubated, who were on anticoagulation, and who had symptoms of less than 7 days. This was a similar subsequent study of patients who received convalescent plasma from Houston Methodist Hospital. This was also an observational propensity score matched analysis with a lot more patients. Their primary outcome was mortality within 28 days. There was no statistical significance in overall mortality, but when they looked at subgroup of patients who were transfused within 72 hours of admission, there was a statistically significant benefit in that subgroup. And also in the subgroup of patients who were transfused within 72 hours of admission with plasma and also had antibodies and were given plasma which had a fairly high titer of antibodies. So then we go into the two randomized trials for convalescent plasma. And the first was the placid study, which was published in the British Medical Journal. And this is an open label, multi-center randomized controlled study in India. Patients were hospitalized, confirmed COVID-19 patients, 464. They call it moderate COVID-19, but they actually meet criteria for severe based on our definitions. And one of the only criteria other than the respiratory rate, the oxygen saturation, the PaO to FiO2 ratio was the availability of a matched donor. The primary outcome looked at was progression to severe disease and all-cause mortality at 28 days. I want to so this study was run between April and July. And at that time in India, when they started the study, they did not have a platform to measure SARS-CoV-2 neutralizing antibody titers. And so this was not routinely done when the study was initiated. They did collect a vial of a tube of blood from all plasma donors to do these studies later on. This study did not show any difference in progression to severe disease or mortality. There was no difference between the two arms. Median duration of symptoms was about 8 days. So what was interesting about the study was that when they went back and looked at patients who had neutralizing antibodies, almost 83% of trial participants, that's patients who received convalescent plasma, had neutralizing antibodies at enrollment at a median titer of 1:90. Also, about a third of convalescent plasma donors did not have detectable neutralizing antibodies. So this was a situation where the donors were usually individuals who were young, who had recovered from mild disease and had lower neutralizing antibody titers than the recipients who were all hospitalized patients with severe disease and had significantly higher neutralizing antibodies at enrollment. There's a lot we can learn from this trial, but it is the applicability of this data to settings where antibody titers in both plasma donors and recipients can be measured, like our hospital, is unclear. So that's where we are with that, with the placid trial. And finally, a couple of, I think last month, there was yet another randomized trial of convalescent plasma, this time from Argentina. They looked at patients with COVID-19 pneumonia, randomized in a 2:1 ratio to receive either convalescent plasma or placebo. The primary endpoint was the clinical status 30 days after transfusion based on the WHO clinical scale. And again, the median time from onset to symptoms was about 8 days. This trial also did not find any significant difference between groups in the distribution of clinical outcomes, mortality, ICU admission, and invasive ventilatory support requirements. Knowing that there had been benefit in patients transfused within 72 hours based on prior studies, they did look at this very small subgroup of patients who were given transfusions within 72 hours and did not find any significant difference between the transfused group and placebo. So again, looking at this trial from the lens of antibody titers, this was another trial where they were not able to check antibody titers on all patients. So only about 215 participants, that's about half the number in the study, had antibodies at baseline. About half of the participants in both the convalescent and the placebo group did have antibodies at entry into the trial, and median titer was about 1:50. 56% of the plasma, of the infused plasma, was available for analysis and did have a median titer which was fairly significant of 1:300. They did post hoc analysis of patients who did not have antibodies at baseline, and this did not show any significant difference in outcomes, but this was a very small number. So this is where we stand with convalescent plasma. It has an emergency use authorization in this country as of September of this year. The FDA did their own analysis on the Mayo EAP data. Like I mentioned, a large number of patients have been transfused with CP under the Expanded Access Program. The data generally supports safety. Factors that contribute to efficacy include duration of illness before transfusion. So whether you're giving it within 72 hours from diagnosis, 72 hours from symptom onset, or 7 days from symptom onset, I think that makes a difference. The severity of illness, whether patients are intubated or not, makes a difference, and the antibody titers. Data suggests that there is a mortality benefit in certain subpopulations getting convalescent plasma with high titers of antibodies. So we still have it in the Mount Sinai health system. We are giving it as an investigational product because at this point, the EUA specifies looking for antibodies with a particular kind of a platform, and the Mount Sinai health system is working on that. So in the meantime, we still have it as an investigational product, and we have moved to a rapid antibody-based utilization of convalescent plasma. So all of our COVID-19 patients are seen by ID, and if there is a consensus that this patient will benefit from convalescent plasma, we recommend sending a rapid antibody test, which has a turnaround time of about 4 to 6 hours from taking into account transportation. And we only recommend using convalescent plasma if the rapid antibody test is negative. The EAP did not really specify the titer of antibodies in convalescent plasma, but internally, Mount Sinai Health System, because we had the ability to look for neutralizing antibodies fairly early on in the pandemic, we used a cutoff of at least 1:320, even for our EAP patients. So we have some idea of the titers of antibodies we have been giving our patients. So where does convalescent plasma fall in all of these guidelines? So the NIH does not recommend for or against. The IDSA treatment guidelines recommends the use of convalescent plasma only in the context of a clinical trial. These are the updated IDSA guidelines, which closely aligns with the NIH guidelines in the use of dexamethasone and the patient populations for whom remdesivir might be helpful. And these are our Mount Sinai Health System guidelines, which again which were recently updated after the 3 EUAs that came out in November and the 1 FDA approval in October. So we have, for our patients who are symptomatic and not requiring supplemental oxygen in either the hospitalized or the ambulatory setting, supportive care is what is primarily recommended. For those in the ambulatory setting, we have a process of giving antibody therapies for patients who are at high risk for disease progression. Hospitalized patients requiring low flow nasal cannula, we do recommend anticoagulation, convalescent plasma if the rapid antibody is negative, dexamethasone and remdesivir. For hospitalized patients requiring non-rebreather, high-flow nasal cannula or non-invasive ventilation, the same 4 modalities are to be considered. And for hospitalized patients requiring mechanical ventilation or ECMO, dexamethasone and anticoagulation is what is to be considered. We do not feel that there was sufficient evidence to include baricitinib into these guidelines at this time. Other therapies which we do not use, current data does not support the use of the IL-6 inhibitors, which were so widely used in the earlier days of the pandemic. We were a site for the sarilumab trial, which did not show any benefit in clinical outcomes. Tocilizumab in October, I think there were 6 studies and press release from the manufacturer on various toci clinical trials, which have not been, generally not been positive. So there is Covacta. You can go into all of this. The only one that did show some positivity, and this has not been published in a peer review, it's a manufacturer's press release, was Impacta, which basically randomized patients to receive tocilizumab or placebo, but had 85% of patients from racial and ethnic minority groups. The primary endpoint was death or mechanical ventilation by day 28, and toci did reduce the risk of mechanical ventilation, but not mortality. And again, this is from a press release. Other treatments like hydroxychloroquine, chloroquine, azithromycin are no longer approved by the FDA for the treatment of COVID-19. They were under an emergency use authorization in March and April. And we have data from large cohorts like Recovery and Solidarity which showed futility for the use of these drugs in hospitalized patients. What is coming down the pipeline? We are looking to start our studies on hyperimmune globulin over the next several weeks. There will be PK/PD studies primarily done, which is going to be done at MSH, and then after that, we are going to be a site looking at the safety, tolerability, and efficacy of hyperimmune globulin in the treatment of adult hospitalized patients. And I have one last slide on what happened to bacterial and fungal co-infections during COVID-19. There were 2 studies looking at it. One was a meta-analysis kind of earlier in the pandemic, and more recently, an observational cohort study from Montefiore looking at bacterial and fungal co-infections. 72% in both studies, the number was pretty much the same. Over 70% of COVID-19 cases did receive antibacterial therapy. But when you looked at the number of microbiologically proven co-infections, it was about 8% in the meta-analysis and 3.6 in the Montefiore data. The Montefiore data also looked at the susceptibilities on antibiograms at similar times in 2019 and 2020 and found decreased susceptibilities. There are many reasons for our use of antimicrobial therapy. Severe COVID is indistinguishable from bacterial and fungal sepsis. Most of our patients were in the ICUs with central venous catheters, mechanical ventilation. We did use a lot of corticosteroids and other biologics, prolonged hospitalizations. Patients had multiple recent healthcare exposures. So there was enough reasons to use the antibiotics that we did, but wearing my ASP hat, and especially as we are in the middle of another surge, we need to look at this more carefully. That is all I have for now. I can, how are we doing with time? Yes, we can pause and I'm happy to take any questions, or I also do have some of the system slides on COVID vaccines if that is something you want me to share.
So Dr. Koshy, there's a question in the chat about segregating treatment based on the timing of the start of symptoms. Do you think that patients who are early in their presentation would be more likely to benefit?
Yes, absolutely. So when we're looking at patients who were hospitalized, almost all of the Remdesaver studies, the median duration of symptoms before they got Remdesaver was somewhere between 6 to 10 days. So definitely, when you look at convalescent plasma, the data up to giving it within 72 hours, definitely, seems to make a difference in terms of efficacy. So yes, earlier on in the course of illness matters, except for dexamethasone, where there was a statistically significant benefit in patients beyond 7 days of symptoms. Ivermectin, okay. I've been hearing a lot about it. As far as I know, there is one study that looked at ivermectin in hospitalized patients. It was a retrospective cohort and did lower all-cause mortality. This was the study that was published in CHEST. The studies in the ambulatory world, as far as I'm aware, and I am not up to date on this, was primarily, I think there's a study from Bangladesh, which is not yet in preprint, which showed some benefit. There's a study from Iraq, I think, which showed benefit. So I don't know. I'm not sure where we stand. Both the national societies have not made a recommendation. They feel that there is insufficient data to make a recommendation at this point. Sorry, I don't understand this. Have there been any studies that look at man prophylactically? I'm not sure. Oh, monoclonal antibodies. Prophylactically, yes. So there are studies looking at it. We don't have data as yet. Regeneron has a study. Mount Sinai Health System is enrolling for patients to get casirivimab, imdevimab, for patients who are exposed to COVID without a COVID-19 diagnosis. And it is ongoing. That's Regeneron 2069, and we hope to have data soon.
We've got to wrap up in about 1 minute because a bunch of folks have to run to interview. Is there a 60-second version of the vaccine story that you can tell?
A 60-second version of the vaccine story, especially after they published the Pfizer studies in the New England Journal over the weekend. Well, we've seen a lot of how the mRNA vaccine works. I want to point out that there have been mRNA vaccines in clinical development from 2017. So while the technology is new and we don't have vaccines, they have been studied. This I don't want. Everyone is aware of the efficacy data. I'm sure everyone has seen the data from the Pfizer trial looking at responses in terms of COVID after a single dose. This is the placebo. This is the placebo arm, and this is the patients who got COVID. I actually want to make one pitch for the two other studies, which is AstraZeneca and I thought I had the AstraZeneca one, but I don't think so. But and the Janssen study, we are actually currently enrolling for the Janssen adenovirus vector vaccine study at Mount Sinai Queens and Mount Sinai Brooklyn, and want to point out that this is one of the single injection COVID-19 vaccine studies, and um, and I think that is it. I did have a slide on AstraZeneca, but I don't seem to find it right now. But all of the vaccine information for the hospital is in this site, mountsinai.org, COVID-19 vaccine information. So I wanted to put that out there.
And somebody asked if you could repeat the email address for people who need outpatient therapy.
Yes, COVID therapeutic referrals at mountsinai.org. Let me just get to that slide so that I can put that up there. There we go. COVID therapeutic referrals at mountsinai.org.
Excellent. Thank you so much, Dr. Koshy. Really appreciate it. Take care, everybody.
Bye-bye. Thank you.